All right, so Spinal Anatomy, it is spring of 2020. It's week 2. It's Tuesday. And we were talking about the sacrum. We talked about the anterior anatomy of the sacrum. Let's turn to the posterior side. Now, the anterior side, remember, was nice and smooth, but the posterior side is a pretty rough surface. Specifically, there's 5 mountain ranges that run vertically, or sagittally, you could say as well, that we'll look at. The first one is the median sacral crest. There's only one of these, and it runs right down the center of the sacrum. It's made up of kind of spinous processes like are seen in the lumbar spine and thoracic and cervical spine, but they're stubby. Therefore, we can't really call them spinous processes. Instead, we have to call them spinal tubercles. They're formed by the union of the lamina on each side, kind of gives rise to the root or the base of the spinous process. Let's take a look at these little spinous tubercles. So there they are. This is a P to A from the back view of a sacrum, and you can see there's usually 4 of them or so. So 1, 2 here, 3, and 4. These 2 are very close together. Notice that the 5th one is gone. We have a little spina bifida here, which is natural. We'll talk about that when the time comes. Anybody see anything weird with this setup, though? I gave you a hint. Where's L5? Remember we talked about basic of the lumbar spine, the basic vertebrae. Remember the basic vertebrae should have vertebral body, and it should have 2 little airplane wings coming off, right? That's not what we have here. Look at all this bony growth. So this is called a transitional segment. Specifically, it's called sacralization of the L5 vertebrae. And it's seen in about 7% of the population or so, 5 to 7, depending what research you read. In your practice, you'll probably see maybe 10-15% of your patients will have this. Why? Because it's related to chronic back pain. So you'll see a bigger prevalence, and you should always explain to the patient that they have this, because if they do have it, they probably are not going to get better quite as quick as your normal patients do. On the other hand, these are going to be good patients because the pain usually does come back if they have a structural abnormality, which I'll show you in a minute. Now this patient, you can see this is called spatulization of the transverse processes. There's no joint here per se. They're like grown together. Over here, we'd have to look at MRI to see. Now there's also a new little hole for the posterior ramus of L5, which it's not supposed to be. It's supposed to come over the back of the sacrum, the L of the sacrum normal or freely. So you can get bone spurs and you can get compression of these nerve roots in this abnormal hole. So that's called sacralization. I do like Kent sacralization. Right, let's look at some more of these. Here's a normal vertebrae. This is just the top of the sacrum. Here's the hole. I guess I showed it right here. This is actually one of our models from school. And you can see the L5 bone is right here. And you can see the transverse processes. Right? That's normal. There's no connection to this is the ala of the sacrum. Did we talk about that? I think we talked about that already. You could call it the lateral mass of S1. There's the sacrotubercle here. But there's no connection, right? And then let's look at this guy. See, here's another bone. You can clearly see, this is actually lumbarization, but it's the same type of deal. You can see we got a neoarthrosis formed right here. So if you count the segments, let's say this is 1, 2, 3, 4, we suddenly realize, no, this is one up here. So this is also a transitional segment. This one it's called lumbarization of S1. So this is the S1 sacral segment. This is supposed to be fused into one big block, right? You're not supposed to see anything, the L of the sacrum and the bar, everything should be one block, but it's not. So this one's taken on, this S1 segment has taken on characteristics of the lumbar spine. So you can have transitional segment either way, sacralization or lumbarization. Okay, very important concept. Here's a radiographic view, P to A view of a patient with lumbarization. And this is where you can get into trouble and chronic pain when you're uneven. So this side we have a fusion, there's no joint here. This side looks like we have a little called a new joint, which is called a neoarthrosis. So those can be trouble. You get unequal biomechanical load, you can wear that thing right out. Okay? So transitional segments. This is a patient I had actually last weekend. And these aren't holes, this is a special 3D reconstructed CT. So these are the ilium. They would be filled in. That's just the computers having a little difficulty there. But the point is, what do you think? Well, I mean, this is a scoliosis patient. She had a massive construct from T1 all the way down, surprisingly, to L4. I mean, that's not really that smart, honestly. It's not our country. They didn't do this. You always extend the fusion construct down to the sacrum. This is like the base of the tower. Tremendous biomechanical load is placed when they don't extend the construct all the way down. But that's not the point of this lecture. I mean, there's all kinds of problems with her. She has chronic back pain. What do you see? Well, there's L5. There's a transverse process here. What's the matter with this one? Yeah, it's got a new joint. You can clearly see the neoarthrosis here. See the joint right here? And there's a hole that shouldn't be there. There's a foramen. So yeah, this is L5. So this is called sacralization. L5 has taken on some characteristics of the sacrum. You can also see a nice sacral hiatus right here, which we're going to talk about in a bit. Good. Intermediate sacral crest. Now there's two of these. There's one on each side of the median sacral crest, this intermediate sacral crest. This one's tough to see sometimes. It is located just inferomedially. Again, if you don't know medical directional language, go watch my YouTube video on my main page. I think I gave you a link last time, so you understand that. But inferomedial to the posterior sacral foramen is where you find these. And these guys are really articular pillars that have fused together. They have nowhere to go, so they kind of, when they fuse, they kind of make a little mountain range, a little bump. And so we call those little bumps articular tubercles. I almost always, oh, thank you very much. I don't know why that comes up sometime. This is Windows 7. I guess it's getting kind of old. Articular tubercles, I do like this. Boards like this, you got to know what articular tubercles are. And they make up, the articular tubercles collectively, all of them, make up the intermediate sacral crest. Let's take a look at them. So here is another sacrum. Now if you do have the signed up for the in-person lab with me, if we ever get back here, you can look at these bones with your own eyes and pick them up, and I'll show it to you. But you can see it pretty clearly in these pictures. So there is a intermediate sacral crest running. Let me see. Let me mark it on this side because it's a little harder. But there's an articular tubercle. There's another one here. There's another one here. There's another one here. So that is the intermediate sacral crest that runs like that. Just medial to and slightly, maybe, well, I would say just medial to these posterior sacral foramen. Right? You can see a really nice one right there. Right? So those are articular tubercles of the intermediate sacral crest. Are we good? Good. There's another one. Okay, and then the third mountain range, this is a bilateral structure as well. There's a right and a left. This is called the lateral sacral crest. This one's usually a little easier to see. It is made of rudimentary transverse processes that fuse together and kind of bubble up into a little mountain range. And those little mountain ranges they're not articular tubercles. Because they're made of transverse processes, they're called transverse tubercles. Transverse tubercles. So on this specimen we can see them quite nicely. Transverse tubercles are right there. And so this whole thing collectively is called the lateral sacral crest. Got it? Pretty simple, I think. Right, there's another picture of them, of all of them. Actually, so there's the median sacral crest. Be careful, don't call this the medial, it's median sacral crest. And then we have the intermediate sacral crest, lateral sacral crest. What's this right here? Slit. Oh, we're going to talk a lot about that. That's the sacroiliac joint. It is kind of a diarthroidal joint. It does have an articular surface with synovial fluid. It's strange though because it's not completely encapsulated, but I digress. Posterior sacral foramen, very easy to see. They're located lateral to the intermediate sacral crest and medial to the lateral sacral crest. Right? Those are like when boards and my questions, you need to know where things are positioned. So yeah, basically there they are. So you can see, let's look at this one right here. There's the S1 posterior sacral foramen. It is lateral to this reference point, which is the articular tubercle, but it's medial to the transverse tubercle. See how that works? There's the transverse tubercle. Again, go to that medical directional language video if you're having trouble with that stuff. They are in direct communication with the sacral intervertebral foramen. They are not in direct, that means like they run right into. They're not in direct communication with the sacral canal. And they allow the passage of the dorsal ramus of the sacrospinal nerves. Okay, there's a stubby little, we're going to look at this weird thing here in a second, but there you can see 4 of them. Where's the 5th one? How come I don't see a 5th one? There's 5 sacral segments. Remember we said that lateral sacrococcygeal ligament runs, not going to show up very good here, right there, so it makes, remember we talked about that before. So there's only 4 of them. Or did I ask what's the deal? Yeah, what is the deal with this slit right here? What's going on here? That's called the spina bifida, but it's not a dangerous. In fact, there's no research that there's any increase in low back pain with this thing. It's called spina bifida occulta. You see it here? That's just a slit. This growth center failed to take off, and it fused into one unit. Sacroarticular process, a very important thing. So we have a superior articular process and an inferior articular process of all vertebrae. But sacrum's a little different because we said these superior and inferior articular processes fuse together to form those articular tubercles and that intermediate sacral crest. There's one exception to that rule. The very top one, the very top superior articular process of S1 is a full functioning joint, and that actually connects with the inferior articular process of L5 to form the very, very important L5-S1 zygapophyseal joints. So let's take a look at that here. I guess everything I said. The orientation of these things should be flat. Like this is flat into the plane of the page. This would be kind of sagittal into the plane of the page. I'll show you what I mean by that in a minute. So here's an overhead view. This is the sacral base, S1. This is the anterior, the sacral promontory would be right here, the little lip. Here's the ala of the sacrum, or the lateral mass of the sacrum. And sacral canal is right here we looked at. But here, kind of sticking up, coming out of the plane of the page, we have these sacral articular processes. Right? We can't see the facet on the back of these, but these would connect with L5's inferior articular processes to form the facet joint, or aka the zygapophyseal joint, or the Z joint. So these are very important structures. But notice how they're situated. They're not completely, this would be a completely coronal orientation, which would be parallel with the floor here. They have a little bit of sagittal tilt to them, but not much. Maybe, what is that, 20 degrees, 30 degrees maybe. So that's important. These are normal. On some people, you can have one normal and you can have another one like this. And that's trouble as well. You're going to see a lot of those patients because that's another source of chronic back pain. That's called a facet tropism. Facet tropism. Always look for that. Point that out to the patient when you're doing a report of findings, because those people don't. I was right, about 30 degrees there. From the coronal plane. Yeah, they don't get better they get better, but they're going to be long-term patients probably. Right? So there's a picture from the backside. You can actually see the articular cartilage that's on these and on the bones. It's nice and smooth region. It's not, the cartilage was kind of boiled away or processed away, but I still call it the articular cartilage because it's smooth. So if you're in the lab and getting tested on this and there was a pin sticking in this thing, how would you call that? What would you call it? You would call it the articular surface, or the facet of the superior articular process. If we're in real person class and you're taking tests on models or on real bones, you have to say of the. In fact, usually I make you, before you take the test, I have the group say, okay, repeat after me. Say of the. It's to make sure that you say that, because you lose half points when you don't say that, or you lose full points depending on how I feel that day. And as of late, I just completely mark it wrong because it's too hard to figure out half points. So make sure you say of the. Now if you're taking the computer test, you'll be able to see that. You won't have to remember to write it. Okay, let's look at some images. So this is a CT again. This is a sagittal cut, parasagittal cut, and this is an axial cut. If you don't know what I just said, go watch my video on medical language or medical directional language on my main, not the student page, on the main. It's on my main page. How do you get there? Just Google Gillard Anatomy, and YouTube videos will pop up, and then just go to my, how you can click on all the videos. It'll be right up at the top, medical directional language. All right, so these are nice. The orientation is maybe a little more sagittal than I'd like to see. Remember we said it should be 30 degrees. That's about 45 degrees. I'm going to leave that one because I want you to look at that. But this is just the point. You can see the superior articular process of the sacrum, and you can see the inferior articular process of L5. See how they meet? There's a little black space in there. And we're going to do a radiology lecture. Actually, I have you watch that one online because we don't have time. I have so much stuff to cover. But I'll explain all this, photons, and how this all works. A CT is very similar to an X-ray, only it's made up into cuts. X-ray is like getting run over by a steamroller, so everything is smashed into one view. X-ray, you literally see cuts. And this, in fact, is the cut line. When you see this orange line cutting through this Z joint, that's what you see over here, only in the sagittal plane. All right, so at least these are symmetrical, right? They're both about 45 degrees. See any problem? How come this patient had chronic back pain? They ended up getting a fusion as well and did pretty good. I see part of my my other job is I do consultation for people who've had failed surgery. I work for a spine surgeon for a couple of years, working for another one, with another one now, down in Hollywood. I've got a lot of experience with kind of the inside world of spine surgery, so I know quite a bit about it. I had a failed surgery myself, so I'm my mission in life is to not let other people go through an unnecessary surgery, and that's the number one reason surgery fails is because they have a surgery they shouldn't have. Anyway, look at the Z joints. See that this is normal right here. You can see the space in here, but look at what happens out here. See how the bone gets all fluffy? There's actually a nerve root right in here. And so we're getting some irritation of the nerve root probably from this. But yeah, this is facet arthrosis is one way. It's just arthritis of the facet joint, and it needs to be cleaned up. And these can become a source of pain. It's like a knee that wears out. This one's in much better shape. See how smooth it is here? Much better shape. This one's all beat up, and this is your bread and butter, right? We treat facet problems more than anything else. And they had tried chiropractic. Always make sure they try chiropractic and physical therapy. And I have had zero luck really with acupuncture, but if they want to try, they should try everything possible before having a fusion. Anyway, digressing. So facet tropism is when we get an asymmetry of the planes of the facet. It's common. It's seen in about 25% of humans. Severe tropism is definitely associated with low back pain, and as I said, they can be good patients because you get them better and they come back next year or in 6 months. Or if the facets are really sagittally orientated, they don't stop. Normally when two facets are set up, let's draw two facets here. So here's a superior articular process, so there's a facet. There's the inferior articular process would be back here. Here's the bone. This is, whoops. Alright, so there's kind of a bone set up. Not very good drawing. I can't draw as good as Dr. Doe. That guy can really draw. But I get my message across. So superior articular processes are here. So if this bone tries to slide forward, let's say you're bending over to touch your toes, there's a natural tendency to slip forward. Normal orientation blocks any type of slip. When you're like this kind of a setup, there's nothing to block the slip. And you can slip. You get what's called a spondylolisthesis, means slip of one bone on the other. But you get older people over 50 or so, they usually develop degenerative spondylolisthesis. People your age have isthmic spondylolisthesis, which are fractures. Alright, so here's an old patient of mine. And chronic low back pain, what do you think? I kind of hinted what the problem is, right? Look at the facet orientation. So that one's about 30 degrees. That's normal for L5, S1. How's that one? That's weird, isn't it? They're not the same. So you have unequal biomechanics going through these joints. One of these is going to wear off over time. So that's an example of facet tropism. Okay, creates a biomechanical instability. Yeah, there's a procedure called a rhizotomy. If they fail chiropractic care, a next step before surgery is to block the medial branch. So you have a medial branch coming off the posterior ramus, and it plugs right into this Z joint. And you can do a procedure called a rhizotomy where they burn that thing. They basically kill it. Trouble is there's another one coming from above. These are double innervated, as you will learn. And so you got to be able to kill both of these. And sometimes they get them, sometimes they don't. This can be miraculous. It can completely get rid of people's back pain. They've tried everything, including chiropractic. The trouble with the procedure is these nerve roots do tend to grow back, And sometimes when they come back with a higher density, and you try another rhizotomy and it doesn't work. And then they have to have fusion to basically rotor-root that joint, put bone in there, and let it fuse into one block. And that stops. It's the irritating motion that gets these people. All right. Here is, who is this? This is this year. I can't remember what patient this is. This is a lateral radiograph patient with a fairly successful two-level A-lift. That's the Tiger Woods surgery. You can see this is an A-lift procedure where they fused him here. And then he's had one of these new X-lift. Well, it's not that new, but the X-lift procedure, which is scary thing about that, they go through your psoas muscle, and a lot of these patients, they damage their nerve, even though they use neuromonitoring. I have a lot of clients who have had these X-lift, and they end up with radicular pain that they didn't have. Their back pain is better, but it creates radicular pain. So you have to be very careful of that procedure. So the patient did well. The oswestry was a 30%, which is about par for the course for a 3-level fusion. Not everybody gets to probably 0 to 5% like Tiger Woods after a fusion. This was single level though. Sacral neural arch. Do we have a neural arch in the sacrum? We do. Just like we have neural arch we talked about last time in all the vertebrae. It's a little weird looking. The only exception to that rule is down at S5, which has no neural arch. It's open in the back. It has no sacral lamina, and it has no sacral tubercle. And that's a definition of a spina bifida, but that's normal for the human. In fact, most of the time, the S4 and S5 levels have no roof. They have no neural arch, so they're naturally occurring spina bifida. So let's take a look at, here's a sacrum from the back. We just went over this. And let's draw a spinous process would be right here. So the lamina would be right here. Right, that's the sacral lamina of S2. That's the spinous process, spinous tubercle of S2. And the same thing, there's S1, we have, that's the transition. Let's see what we got here. 1, 2, 3, 4. Yeah, so this is just a single. So down here at 5, there's the S4, level. And S5, there's no lamina, or there's no spinous tubercle. Right? These are gone. So that's a spina bifida, but it's a naturally occurring spina bifida. That's actually looks like one level. Looks like the kind of where the S5 level is. But it's a sacral hiatus. You also have these cornua, sacral cornua come off here, and kind of are big bumps, kind of guard the opening here. Now this is usually covered with ligaments, as we said before, but nevertheless, that's a sacral hiatus. 43% of the population, it's a failure of S4 and S5 to fuse together. And 34% of the population, it's just one level S5. What do we make of this? We actually have one of these in the lab. What do you make of that? Well, yeah, it's a massive spina bifida, right? Do you see any spinous tubercles? No. So that does happen every time to time. From time to time you see that. So it's spina bifida all the way up. Not thought to be associated with any negative sequelae though. So there's no, because the dural sac is there, it's still got ligamentum flavum over the top here, and it's still got ligaments protecting it. Here's a nice view from overhead. There's the sacral base of S1, sacral ala. Now we can see a nice view of the sacral canal going all the way down. The roof, what's the roof of the sacral canal? I love that question, hint, hint. Who is not a member of the roof of the sacral canal. You could say the base of the spinous process. Some authors don't include that. They just say lamina fused together. Others say the base, the sacral tubercle makes up part of it. So I'll say the base. I mean, that makes sense to me. So we have the lamina is another part of the roof. And then we could say that this thing, so what is called the articular pillar. So the superior and inferior articular processes also make up part of the roof. Right? I mean, technically this little piece here, that's the pedicle. Sacral pedicle is this region right in here. I mean, that makes a little piece of the roof as well. That kind of connects the roof to the floor. This would be the floor of the sacral canal, and that's just the back of the sacral vertebral bodies. Got it? Here is an old client of mine. This is a 3D reconstructed CT. You can see the sacral hiatus quite nicely here. You can see everything is fused. She has a transitional segment here. So that's almost complete sacralization of L5, but nevertheless, you can see the opening there. That's sacral hiatus. Blow that up. Color it in. Demonstrate my amazing Photoshop skills. There's kind of a S to I view of it. And yeah, medical docs, spine pain management docs, people who've had a L5, S1 surgery and have a lot of scar tissue and you can't do an epidural to try to relieve their pain, you can actually put the needle up this tunnel here, staying toward the roof, being careful not to stab the thecal sac, but you can get a needle up to the epidural space of L5 via that mechanism. Sacrovertebral canal, we've talked about this, haven't we? Formed by the sacral vertebral arch and the posterior sacral bodies. It's always good to know what forms it. Remember, it is unroofed at S5 and maybe S4, and that's the sacral hiatus. That means it doesn't have a spinous tubercle, or it doesn't have or sacral tubercle, or it doesn't have a sacral lamina. Talked about that pretty much already. This is a great, look at all the slides here for first quarter. That's a lot of slides, or a lot of stars. I like this slide. So what is contained within the sacral canal? Well, the thecal sac, aka dural sac, that is contained in part of the sacral canal. It ends at the level of S2. The cauda equina hangs in the thecal sac, so it's also contained by the sacral canal. So the terminal part of the cauda equina. Specifically, we can tell you exactly who's in there. The S1 through S5 part of the cauda equina, those roots that are hanging, are called traversing nerve roots. When they go out the intervertebral foramen, they're called exiting nerve roots. And we have the single CX1 hangs in there as well. And finally, the filum terminale interna and externa are also members of the sacral canal. Here's a mid-sagittal view of the sacrum, and you can clearly see the sacral canal running down the backside like this. You can see the sacral hiatus here. There's a CT view of a sacral hiatus with a patient with a, look at the coccyx. I think we talked about this case already, coccyx bent forward. But we also have L5. What do you think of L5? Where's that disc? Should have a nice fat disc space right here, right? Now she's sacralized, another transitional segment. Another nice view with the roof of the sacrum removed, and you can clearly see the contents. So we can see the thecal sac. Inside the thecal sac, we can see the traversing nerve roots of S1, S2, S3, S4, S5. We can see the filum terminale externa, filum terminale interna, which is inside the thecal sac. Right? We can see all that stuff. This is a very cool picture. I think that's all I wanted to tell you there. The thecal sac, again, we talked about it, but it's so important we can talk about it again. It's a sac of dura mater with underneath the outer dura mater, the arachnoid mater is stuck right to it. So the thecal sac is really made up of, that's why I like to call it the thecal sac and not the dural sac, because it's actually made of dura and arachnoid mater. You remember the three meninges layers? Dura, arachnoid, pia mater. Those are the coverings of the CNS. Where's the pia mater in the thecal sac? It's actually wrapped around the nerve roots. See all these nerve roots? They have pia mater wrapped, even out here, they have pia mater wrapped around them. Okay, so that's where they are, where pia mater is. The space in here, I guess you can't really see it, but you have to look at an overhead view, but the space between the pia mater structures and the arachnoid dura combination, that's called the subarachnoid space. And the lumbar spine, and in the spine, radiology and clinical speak, you don't really call it the subarachnoid space. You never call it that. You call it the epidural space, meaning that it's above the dura mater. Let me think about that. That's not actually right, is it? Epidural space is outside of the dura mater. That would be the intrathecal or intradural space if it's inside. So I need to fix that, slide 44. Try to remember that. But we'll just call it subarachnoid space. Yeah, I'm still thinking about that. Yeah, epidural space means it's outside, and that's where epidural section. Intrathecal would be an AKA for the subarachnoid space, because subarachnoid space contains cerebrospinal fluid. Yeah, I'll fix that. Surprised no student. Sarah's been there for quite a while. No one's caught that. Pia mater wraps around the traversing nerve roots. We already said that. Conus, the thecal sac goes all the way down to S2. It starts at the foramen magnum. Okay, there's nice, with all the cauda removed, except for the filum terminale. I left that in there in this image, but you can see how it ends usually about at the level of S2. And you can see holes, right, where the exiting nerve roots have to branch off of it. So you can see that. Okay, I guess we're done. So, hey, we could keep right on going, but we won't. I'll split these up. So I will see you tomorrow morning, and we'll keep going on this stuff. Email me if you have any questions.